Welcome to Part 3 of Module 3, Non-Pain Symptom Assessment and Management. This is part of the Medication Management in Patients with Advanced Illnesses. I'm Dr. Diana Stewart. With me, I have Dr. Lynn McPherson and Dr. Nikki Brandt. The objectives for this module are to be able to describe the presentation and common causes of neuropsychiatric symptoms at end of life. Given a patient case, identify some red flags for neuropsychiatric symptoms, and list one medication and one non-medication treatment option. The outline for this module will be the discussion of anxiety, depression, and delirium. Anxiety refers to feelings of apprehension, worry, uneasiness, or dread, and I used to feel this all the time when I was in school and waiting for grades to come out. It occurs especially with regard to the future, often without a known specific cause. Patients may also describe anxiety as fear. Some causes of anxiety include uncontrolled symptoms, so if you have uncontrolled dyspnea or pain, these can be major causes of anxiety. Side effects of medications, fear of unknown or the dying process, so this is especially prevalent in the hospice population. Patients may want to know what the dying process looks like, especially given the type of illness that they have. Financial concerns are another cause of anxiety. Just the funeral costs alone can be very distressing to the family, concerns about who has the will and what's going to happen to the house, family conflicts and emotional concerns, spiritual distress, so making peace with some of the spiritual concerns that patients have, and also fear of being a burden can be a big issue for patients who are being cared for by their children. These are some of the triggers that should direct you to report to a nurse or a prescriber, particularly if the patient tells you they're feeling anxious or worried or feel like they're going crazy. Patients may be more restless or unable to find a comfortable position within the bed. Some nonspecific signs include increased respiratory rate, difficulty breathing, and poor oxygenation, although these can also be indications of other things. Shaking, sweating, and also ask the family about the patient's spiritual concerns or issues with the family. The patient may benefit from speaking with a social worker or chaplain, and we can relieve these causes of anxiety without relying on medications. Other ways of dealing with anxiety, other non-medication therapies include counseling, and this could be alone or with family members. Again, relying on our interdisciplinary team and social workers are great at kind of pulling affairs in order and referring patients to different things that can help them. Guided imagery and hypnosis, relaxation techniques, involving spiritual chair and chaplaincy, and cognitive behavioral therapy can help patients identify what their triggers are and how to manage them. Getting into the medications, we want to treat any conditions that are underlying and contributing to a patient's anxiety, such as uncontrolled pain or difficulty breathing. Benzodiazepines are the classic agents that patients think of when it comes to anxiety, and these are good at providing rapid relief of symptoms. Some common examples of benzodiazepines include Xanax and Ativan. Other options are selective serotonin reuptake inhibitors, also known as SSRIs. However, these take some time to get onset of relief, and we typically recommend a trial of 4 to 6 weeks to get full efficacy. Common examples from this class of medications include Zoloft and Prozac. So here we have Miss Lewis, who's a 47-year-old female diagnosed with stage 4 breast cancer. She recently enrolled in hospice care. During the nursing visit, Miss Lewis becomes very anxious and restless. She confides that she recently fought with her husband about giving up, and they're still not speaking very much. Dr. McPherson, does this look like any of the hospice patients that you see?
Oh, I think that's very representative of many of the patients that we have. So many of the psychosocial issues that raise their head at this critical time can manifest as great anxiety.
Absolutely. Which of the following could be contributing to Ms. Lewis's anxiety? Fear of the unknown, financial concerns, family conflicts, or spiritual distress? So Dr. Brandt, what do you think about this specific situation?
I think in this particular situation, her conflict with her husband in terms of giving up is really that conflict that's probably more anxiety-provoking.
Absolutely. And it looks like family conflicts is the correct answer. And this is another situation where having a family meeting or really addressing the family as the unit of care could resolve some of these causes of anxiety. The next symptom we'll go over is depression. This refers to extreme ongoing feelings of sadness, hopelessness, helplessness, lack of self-worth, and/or anger. These feelings can occur as a normal part of the dying process, but depression is really a more severe constellation of these symptoms, and it does require treatment. This depression is different than the type of grief that occurs normally at the end of life. Of course, it's normal for patients to feel sad about a terminal diagnosis. However, feelings of hopelessness and expressions that indicate the patient is giving up or would like to end their life are an indication of something more severe going on. A lot of diseases actually cause depression. Common causes include diabetes, thyroid disease, dementia, alcoholism, and the presence of brain metastases from a cancer diagnosis. Also, you can get a rebound effect from medication withdrawal or side effects of some therapies. So again, these medications can be a double-edged sword. So beta blockers, which are commonly used for the management of blood pressure, can actually cause depression, as can steroids or some of the biological agents used for the management of cancer and HIV medications. Other causes, again, uncontrolled symptoms can really bite you in the hiney if you don't manage them appropriately. Persistent pain and nausea, as well as uncontrolled restlessness and insomnia, can contribute to the development of depression in a patient at end of life. Emotional issues that come into play include the loss of control and independence that frequently accompany advanced illness, fear of the unknown in the dying process, and spiritual distress about what happens in the afterlife. And like our patient case, family conflict and a lack of support can be huge components. You should report to the nurse or prescriber anytime you observe these behaviors. So if the patient tells you that they have no reason to keep going, especially if they have thoughts of wanting to hurt themselves, kill themselves, or others. Frequent episodes of crying, and if they become withdrawn, somebody who is previously very social but is now hardly interacting with their family or caregiver, and if there's a sudden change in appetite, energy, or sleep patterns that's not associated with another cause. Some non-medication options for managing depression include therapeutic counseling and anticipatory grief counseling for the family. Spiritual care has a huge component with this, especially if there are spiritual concerns at play, using guided imagery, relaxation techniques, and massage. And I think massage is a pretty great therapy. In terms of treating depression with medication, some of the things we rely on are actually stimulant medications. Dr. McPherson, could you comment on the role of Ritalin in depression at end of life?
It's ironic, it's almost paradoxical. You would not believe that a stimulant drug would be useful to treat depression, but we frequently reach for this medication, especially in patients who don't have very long to live. So it seems to brighten people up by the next day, and really it's an excellent antidepressant in older adults.
Absolutely. And one of the interesting things with this agent, it does come on pretty quickly and you will see effect right away. But there are reports that you won't see a full benefit from it for a few weeks. So even if you don't see an impressive change in that first day, it doesn't mean you need to get rid of it right away. It might be worth doing a longer trial. The other agents like antidepressants take a little bit more time to get effect. Again, a full trial would really be 4 to 6 weeks. And the selective serotonin reuptake inhibitors, or SSRIs, can be effective for the treatment of depression. Here we have Miss Mason, who is a cheerful 75-year-old who was recently diagnosed with advanced heart failure. She was previously very active in her church and local volunteer organizations, but has recently stopped calling friends and is now refusing visitors at her house. When you question her about this change in behavior, Miss Mason tells you, "They're better off without me. I wish I could just end things now." So Nikki, what do you think about this? Which of the following statements about Miss Mason might be true?
So, based on what she's talking about, you definitely are worried about the concern with depression, just we talked about earlier. And is this depression caused by her medical conditions? Is it caused by her uncontrolled symptoms? I don't think we have enough data to really define that, or her emotional issues. But it doesn't seem like she's talking about thoughts of or harm to herself or others. But I really have to say, based on the information you gave us, I would be inclined to say C.
Absolutely. And even though there is a normal grief associated with diagnoses like heart failure, this seems to be above and beyond what we would expect from the diagnosis. And it looks like C is the correct answer. Moving on to delirium. So delirium refers to an acute change in a patient's mental or physical activity. Some of the hallmark characteristics include changes in their attention or level of consciousness, disorganized thinking, and rapid onset. So one of the common issues is differentiating delirium from dementia. However, I included this stopwatch on the slide to remind you that delirium is something that comes on quickly, whereas dementia is a slower, more insidious decline. And delirium tends to be fluctuating, so you'll see changes, again, in the patient's level of mental and physical activity. This delirium can be hypo or hyperactive, and unfortunately we're much better at recognizing hyperactive delirium because it's easier for us to recognize. But if somebody becomes less involved with their care or with caregivers, this could be a sign of hypoactive delirium. Delirium is very distressing to family and caregivers, especially if their loved one is suddenly unable to recognize them or hold a conversation that they would normally be able to have. Causes of delirium can be from organ failure, especially liver or kidney dysfunction, and these tend to cause these chemical imbalances in the body that really throw the brain off. But delirium is worsened by a lot of different things. So Lynn, are medications really causes of delirium?
Absolutely. We have so many medications that can bring on or worsen delirium. Ironically, even some of the drugs we use to treat delirium can cause delirium. I think one of the biggest offenders is the whole group of drugs that have anticholinergic side effects. And I know Dr. Brandt could talk for 3 days about those medications because we try to avoid them in older adults. But you just spent in the last portion talking about using those drying agents, the anticholinergics, to dry up secretions. So it really is a tightrope that we're walking to treat symptoms and not cause more side effects.
And I think one way to approach that is really just to monitor the patient carefully. If you initiate a medication to treat one side effect, you want to ensure that you're not causing another problem. Other causes of delirium include dehydration, infection, hypoxia or a lack of oxygen, brain metastases, and sleep cycle disturbances. So Dr. Brandt, do they ever talk about sleep hygiene in long-term care facilities?
Of course, we talk about sleep hygiene. I think it's important to look at a person's day activities and how they're spending their day. Oftentimes, there may not be activities going on, and they're just sitting in the chair and they're napping throughout the day. So that perpetuates poor sleep cycle. Good sleep hygiene, and of course, then looking at how we can optimize programming and activities throughout the day is really important.
All good things. You should get in touch with a nurse or prescriber anytime you observe a patient who's unable to lie still or repeatedly attempting to get out of bed, if they're picking at the bedding or grasping at the air, and again, sleep hygiene, so if they have those altered sleep patterns, napping throughout the day and then an inability to sleep at night. And this can be just awful for caregivers. Patients who are up all night and not kind of interacting during the day really doesn't mesh well with caregivers, especially if they're staying with an adult child who works and then comes home and needs to get rest but can't because the person they're taking care of is awake all night and trying to get out of bed. Delirium can be accompanied by hallucinations, garbled or confused speech, changes in level of consciousness, and again, if you notice that the family is particularly stressed or exhausted more than usual, ask about the presence of delirium. How do we treat this? Non-medication therapy plays a huge role, not just in treating, but also in preventing the development of delirium. Anytime patients are in a facility, you want to maintain a calm, quiet environment, so those loud conversations in the hall can actually be quite damaging to patient care. And this even includes distracting noises, such as having the television blaring. And one of the things I love to see is actually giving patient headphones. So if they're listening to a television show, it won't distract a patient in the bed next to them. And again, really try to minimize loud conversations outside of the room. Especially if patients can't see who's talking, this can be very disorienting to them. We encourage a regular sleep cycle, and like Dr. Brandt mentioned, having activities during the day is very important, but at least, at the minimum, we should be keeping the lights on during the day and off at night. But this is really difficult to do in the hospital, especially if nurses are coming in to check vitals or give medications in the middle of the night. Easy ways to orient the patient include placing small reminders throughout the room. And this could be a clock so they know what time of day it is, or calendars so they can keep track of the month and the year, newspapers and photographs to remind them of their family and friends, and address any reversible causes such as underlying illnesses or medications that might be contributing to delirium. Unfortunately, there's no evidence to show that preventing delirium with medications is beneficial, and it can actually be harmful, so it is not recommended in current guidelines. Once patients do develop delirium, we can treat it with a few different agents, but our real workhorses are the antipsychotics. And Dr. Brandt, I think again, this is an issue where we worry about the appropriate use of antipsychotic agents.
Yeah, and I think, Dr. Stewart, you bring up a great point. As we talk about, you made a clear distinction between prevention and treatment. Sometimes we're using antipsychotics for prevention of delirium in high-risk patients where the evidence is not very well substantiated. In those who have active delirium, especially in a hyperactive state where they're a harm to themselves and maybe others as they're thrashing around, using these agents may help with that course. But again, that judicious use, the shortest period of time, and making sure that we're looking to see if they're effective is critical.
And, I think it's important to recognize that when some people who have these delirious episodes, it's really frightening. They think the alligator really is under the bed, or the boogeyman's in the closet, or that people are molesting them in the middle of the night. So if we can use a medication to relieve these very distressing symptoms, I think that's a kindness. I think it's actually a moral imperative to do that. So we cannot evoke a blanket rule outlawing a whole group of medications that can palliate these symptoms that can be terrifying for patients.
No, and you're right, Dr. McPherson. I think, but you're describing target symptoms that these medications treat, right? So you're talking about hallucinations, you're talking about a hyperactive state where they're decreasing their function because of those hallucinations. The psychotic symptoms, too often than not, people aren't as discreet in terms of identifying what we're really using these medications for. So we'll talk a little bit more about appropriate versus inappropriate use of any class of medications, whether it's antipsychotics, because one could argue, as we talk a little bit about benzodiazepines, there's also concerns with those medications as well.
I always get nervous if I see a benzodiazepine written on the chart without a clear indication, because if they're using this to manage delirium, especially hyperactive delirium, these agents can actually worsen the situation. So you want to avoid the use of agents like lorazepam or Ativan in patients who are delirious. So let's see what we've learned so far. How is delirium characterized? By changes in attention or level of consciousness, organized thinking, a slow onset of symptoms, a steady presentation, or all of the above? Dr. McPherson, what do you think?
Oh, that's pretty tricky, because when you see an all of the above question, you always want to pick all of the above.
That's how
but
I
it's
got
not
through school.
all. That's right. It's not all of the above. I think it would be A, changes in attention and our level of consciousness.
You are right on the money with that one. And that is, again, one of the hallmark changes to assess to compare delirium versus dementia.
And I just want to point, that's the importance of knowing your patient and knowing their history, and understanding and following them over time is critical to see that acute change that sometimes gets missed. But it's also important to note, and always try to train practitioners, is that patients who have dementia because of the neurochemical imbalance are at a greater risk for delirium.
Absolutely.
So we have to pay attention to that too.
But you look at slow onset, and I agree, it is rapid onset. Dr. Brandt, can you spend just 15 seconds talking about sundowning?
Oh, sundowning. Well, I want to actually talk about slow onset and then the slow offset of delirium. People think because it's an acute change that when you get rid of the offending drugs, when you treat that, the delirium may completely resolve quickly. It may take months in older individuals. Sundowning, however, is a different phenomenon. Sundowning is often described later in the day where patients start exhibiting symptoms such as agitation, or maybe they're experiencing things such as hallucinations or delusions. experience. And there's a lot of theories behind that. I know we could get into some discussion about that, but it is very stressful to the families. And you may think, oh, is this a delirium? But you really got to look at the patterns of when this change in behaviors occur. And typically it's later in the day when the sun's going down, and they believe some of it has to do with the visual cues that's happening. So, yep.
There's still so much that we don't know, but it's fascinating to really look more in detail about some of these symptoms at end of life. If you're interested in learning more about non-pain symptoms in patients with advanced illness, please check out the Fast Facts, which is hosted by the Palliative Care Network of Wisconsin, and you can find that at the link below. This concludes Module 3, Part 3, Non-Pain Symptom Assessment and Management, and we'll see you back here for Module 4.